Yeah, so I have quite a few slides. I will be tying in some of the recent cases that we have experienced in our ABC and trying to bring in the more of a local practice into this slides. So the first slide, we have to address the terminologies of IUGR. And as many speakers have already illustrated in the early morning, that there are many controversies and that there must be a definition of what is the potential of a fetus in terms of its growth. So we have in terms of ethnicity, we have in terms of the passport that the mother is holding, right? So the general definition of IUGR is the failure of the fetus to meet the growth potential, and how we define it, okay, is controversial. But it is generally due to a pathologic factor. And the general definitions that we've been using will be that of the EFW or AC below 10 centile, and this is according to the Society of Maternal Medicine. However, ISUOG, ISUOG, and the Delphi consensus has a slightly different view. Again, we take into account the EFW of less than third centile. However, we also take into account fetuses that have a growth of less than 10% with an abnormal Doppler study. And these fetuses are at increased risk of stillbirth and perinatal mortality, with those with the birth rate below the third centile being at the higher risk. We also have to differentiate between the early persistent late onset IUGR, and our cutoff is around 32 weeks. And FGR due to placental insufficiency, according to this ISUOG guideline, is classified as below. As you can see in terms of the charts that we have here, there are some specific criteria that the fetus must meet in terms of early and late onset FGR. So for the overview of my talk, I'll be covering some of the causes of IUGR, and of course for today we'll be emphasizing on the genetic causes. I'll be talking about the clinical approach to IUGR in general and what are the actual genetic causes of IUGR. So in the morning, I have had the pleasure of having Lauren, who have already gone through some of the slides and some of the papers as well as Riching. So I hope this will be a refresher for everybody. So there are many causes of IUGR, and it can be broadly divided into maternal, placental, infections, and fetal factors. However, in a lot of studies, we can just briefly differentiate them into placental-mediated and non-placental mediated. And in terms of genetic causes, if we look at the fetus, if there are genetic disorders of the fetus, we are looking at chromosomal microdeletions, duplications, single-site mutations, as well as epigenetic disorders. However, do not forget that the pregnancy is a maternal and placental unit. And at the same time, we'll be looking at the placenta having a genetic issue, and that will be that of confined placental placenta. So if you look at the fetal guidelines, it presents a very nice flow chart in terms of the approach to a fetus with suspected FGR and how we should approach in terms of investigations, management, and the eventual delivery. However, we'll be focusing on this part here. And first of all, if we notice that the fetus is growth restricted, we will take a detailed history because the very first thing is we need to ensure that the gene is correct. The second thing we need to do is a detailed structural scan for any fetal anomalies, soft markers, and sonographic signs of fetal infection. And of course, our Doppler studies to look at how much of this growth restriction is contributed by placental cause. And we're looking at umbilical artery, uterine artery PI, and our CPR. The next thing we look at is our fetal infection screening. So as we are very familiar, the CMV and the toxo parasite is one of the most common fetal infections that we suspect. However, in certain countries, they are endemic for rubella, varicella, syphilis, and Zika, and malaria. We need to take these intra and uterine infections into account. And the next thing is genetic testing for karyotype and CMA, and of course, I will elaborate later further about what we need to do under point number 5. And the latest hot topic of discussion is androgenic markers. And how much do we attribute the androgenic markers in terms of risk assessment for IUGR features? So for the RCOG guidelines, in most recent published 2024, actually there is little evidence to support the use of androgenic markers. We are still under the more of stratifying whether the fetus or the pregnancy is at risk of preeclampsia. However, in our local setting, we are using serum PLGF to give us an idea of whether this fetus may or may not have placental contribution to the FGR. So if you look at these investigations, and if you look at the question of whether the IUGR fetus could be genetically abnormal, we can ask ourselves several questions. First of all, in the history, okay, are there absence of risk factors of placental insufficiency, or are there absence of any evidence of congenital fetal infections? Has the mother been well during the pregnancy? Did she ever had a fever? Does she have a child who was recently ill? So these are the things that we can delineate some of the causes. The next thing is on the structural scan, what are we really looking for? So of course the presence of structural anomalies and soft markers. However, the AFI is also very important because in the presence of polyhydramnios, then we will be a little bit more concerned about underlying genetic hypothesis. So Wei-Ching has mentioned about shortened fetal long bones, especially when they are short, less than -4 ST, then we have to think about skeletal dysplasias in association with the XDR. We look at absence of markers of fetal infections like calcifications, placentalomegaly, to exclude the possibility of a fetal infection. However, an isolated IUGR does not exclude the genetic diagnosis, and this is emphasized by the legal as well. For Doppler studies, there's a normal umbilical artery Doppler tell you that it's not placental dysfunction, that is good. There's an abnormal umbilical artery Doppler. Is it pathognomonic for placental dysfunction? It is not. And is a normal uterine artery Doppler helpful? I would say from the last few speakers, it is helpful to tell us whether or not there's any evidence of primary placental growth restriction. We can keep that in mind. So for the next 2 points, okay, we can offer fetal infection screening, and if the mother is concerned about invasive testing, we can counsel her for maternal serology for CMV and toxoplasmosis. And as I previously mentioned, we can use the serum PLGF in our local setting to see if there is an element of placental dysfunction. So let's look into the genetic causes of IUGR. And now the topic of interest will be the baby. So I have a recent case to share. So as you all know, I run the twin clinic, so some of my cases will be actually twins, okay? But twins are also at risk of fetal growth restriction. So we look at this lady here. She's a 38-year-old, para 2, BMI 40, spontaneous pregnancy, 2 previous cesarean sections, and of note, both the birth weight were more than 4 kilos. Yeah. So this mother has some medical problems of endometrial hyperplasia and have regressed and conceived. Okay, and this pregnancy was MCDA twins. And we noticed at week 15 that the growth of both babies was growth restricted. And in KK, we use what we call standard deviation of AC. And our cutoff for -1.8 shows that the fetus is at or below the 3rd centile. So in this situation, the Dopplers were normal. There was no weight discrepancy. So there was a similar findings on the scan to about 18 weeks. At 19 plus 6 weeks, we did a structural scan. We found that twin A has a hypoplastic nasal but no other anomalies, and Dopplers were normal. And twin B similarly showed a hypoplastic nasal bone and bilateral CPC. However, this patient, she was not interested in any Down syndrome screening from the beginning, and she wanted to carry on this pregnancy anyway. However, we counseled her on the age-adjusted risk with the hypoplastic nasal bone, and offered her at this point amniocentesis, but she declined. At 21 weeks and beyond, there were similar findings. However, there were some evolving findings in twin B with bilateral pleural effusion. However, there was no high drops. So in this situation, we kind of discussed again the role of prenatal testing in the situation. However, because this couple was very fearful of the risk of miscarriage, procedural related miscarriage from invasive testing, she decided to do an NIPT. And this is the NIPT result. So at this point, if you look at this result, I'm not quite sure whether we have an answer for her. This is a high-risk T18 result, and we know that the concordance of T18 for the NIPT may be a little bit uncertain because we are unsure of whether it could be a confined placental mosaicism or that the fetus could be a true trisomy 18. And hence, we counseled her for an amniocentesis. However, this amniocentesis was performed only at 25 plus 5 weeks, beyond our upper limit of termination in Singapore of 24 weeks. However, the argument is that the couple wanted to know if the fetuses were affected by trisomy 18 or not, and hence this could help them to plan the delivery and the peripartum management of the babies. And true enough, when the returned at 27 weeks. This showed that both fetuses were affected by trisomy 18. I think the audience is not unfamiliar with the diagnosis of trisomy 18 and what are the implications. Okay, and we know that majority of the cases of trisomy 18 babies do not live past the first year of life. And survivors will typically have very severe developmental delay as well as cognitive disability. And I think we do not have one that lived past 8 years of age here locally. So we explained to her that even though the ultrasound findings do not suggest a major brain or heart abnormality, however, the genetic diagnosis still suggests trisomy 18, and we are unable to exclude in this situation the intellectual disability. So we referred this couple to palliative medicine, and we decided on comfort care of babies at delivery, and eventually the patient herself requested for delivery at 24 weeks, as she had other medical conditions as well, and the overall difficulty of pregnancy. So twin 2 actually demised immediately after delivery, and twin 1 was sent home with the baby care. So what does this case tells us? So actually on the ultrasound for this patient, there was actually very low structural defects. However, there were some subtle soft markers on the scan. So in this study in 1993, this was one of the first studies that started to define what are the chromosomal abnormalities in association with fetal growth retardation. And from this study, we know that the contribution of chromosomal anomalies as a cause of FGR was established to account for about 19% of cases, with trisomy 18 and triploidy being the most commonly found anomalies. However, you will notice that this is a 1993 paper, so although it was frequently quoted by major societies, this was an era that was actually before the time of Down syndrome screening. So in a later publication, okay, in 2017, we actually found that in apparently isolated FGR, and some of these cases in this series, some of the invasive testing was done as late as beyond 32 weeks. And you can see that in third trimester, it actually used normal karyotypes. So it shows that, you know, even in apparently isolated FGR, this yield for the abnormal karyotype was found to have decreased to 6.4%, because pregnancies that had already been screened for aneuploidy in the first trimester would have already been accounted for during that period. So for triploidy, we're actually looking at a very classic presentation of very, very early onset IUGR. And this happens when the fetus obtains 69 chromosomes. It can be from 2 sets from either the father or the mother. And this prevalence at the point of 16 to 20 weeks of gestation is 0.002%, because majority of the cases actually miscarry in the first trimester. And the classic is the first trimester onset of intrauterine growth restriction. However, if we look at the ultrasound, there could be other associations with latent placental molar changes, as you can see in this scan picture here. And if, let's say, it was a double paternal contribution, then the growth restriction could be milder. However, you can see the classic multicystic placenta. It will be a double maternal contribution if this, the growth retardation was a little bit more severe. So now we move on to case number 2. So case number 2 is also a twin as well. So this was a primate, very much wanted pregnancy, single embryo transfer. It resulted in an MC twin pregnancy, confirmed at 8+3 weeks, so there was early dating. So you can see on the FTS that it was pretty much unremarkable in terms of the risk of T21, 18, and 13. And the NIPT upfront was also low risk for this couple. However, when we started our MC twin scanning protocol from week 16, we found that there was profound growth restriction for both the twins. And as you can see that both daughters were normal. At this point of time, we also offered her the usual workup to exclude maternal infections, and her serologies were actually negative. At 18 weeks, the growth restriction became a lot more profound, okay? And we also noticed that, again, the daughters did not show any much change. And at this point, the impression was that a very severe early onset IUGR of both twins. There was some degree of discrepant DBP. However, at this point of time, we did not think that this strictly met the criteria of DBTS. However, in terms of the very severe IUGR, we decided to offer her amniocentesis for CMA and WES, and at the same time to send the amniotic fluid for infection PCR. So we did the amniocentesis at 19 plus 0 weeks. Okay, and while we're waiting for the results, actually, unfortunately, the week after, the twin B actually released. So this was the result that returned to us. As you can see, it's quite a complicated sentence over here. Okay, but the result is concurrent with a pathogenic deletion within the chromosome of 2q, 32 to 2q, 33. And this syndrome is what we call a Glass syndrome. And Glass is one of the doctors who discovered this condition in 1989. And this condition is actually marked by very severe pre- and postnatal growth restriction, intellectual disability or verbal severity, and dysmorphism, which some of these facial features may or may not be able to be picked up on the ultrasound. And for this patient, up to the point of twin B demise, there was actually no noticeable fetal anomalies on the ultrasound. So in terms of this abnormal CMA, we had to counsel the patient. This was an IVF pregnancy. She still had one embryo left. So the patient had some questions about whether or not she could test the remaining embryo for a similar kind of pathologic loss. Okay, and as I mentioned before, there are some of these features that's associated with Glass syndrome. So what we did was to refer to our friendly geneticists, okay, to help us with the counseling. And of course, parental testing is on the cards because we have to check for the carrier status. And we offered the patient and the husband fish and parental karyotyping. And for future pregnancy, okay, we have to have a discussion with the IVF specialist to see whether or not this couple could be eligible for any pre-implantation genetic testing for this deletion. Okay, so in terms of papers for chromosomal microarray, I think this morning Prof. Laura has already showcased some of them. However, we can still go through them. In the 2017 paper, we talked about the chromosomal microarray analysis in fetuses with growth restriction and normal karyotype, and what is the incremental yield of CMA in these cases. So I think for most of the major society guidelines, it has been generally accepted that CMA has an incremental yield of about 4% over karyotyping. And out of these fetuses with isolated FGR and normal karyotype, these are the abnormalities that were picked up. However, in the presence of fetal abnormalities, the incremental yield of microarray over karyotyping is even higher at 10%. Okay, so these are the the list of the abnormal CMA that was generated from this study. And in summary, what are the commonly encountered pathogenic imbalances? So we have 5 cases of 22q11.2 microduplication syndromes, which may have some overlapping clinical features with 22q11.2. We have 3 cases of XP22.3 deletion syndromes, which were associated with X-linked diagnosis, as well as 3 cases of Williams-Morgan syndrome, which is the 7q11.23 microdeletion. However, as we interpret papers talking about IUGR and things like that, we must take into account that there's really a very high variety of how we define what is IUGR. And simply at the point of time, there was a lack of definition. There was no Delphi consensus at the time to centralize the definition. And also, there's a lack of consensus in the clinical management of this condition worldwide. And also the clinical design, the use of different CMA platforms, and the sample size of these studies also contributes to whether or not this information from the study is reliable. However, the authors conclude that the CMA analysis provides a 4% incremental yield in a non-malformed FGR fetus with normal karyotype and a 10% incremental yield in a malformed FGR fetus. And so the conclusion is this could allow fetal medicine specialists to improve antenatal counseling in cases of isolated FGR by improving diagnostic accuracy. This is another paper, which is a French paper. This is a retrospective study. So because of the flaws of the systemic review that was done, they decided to have a review of 682 significant fetuses with FGR and no ultrasound abnormalities that were referred to 13 French fetal centers in 2016. They had a very strict criteria of what is IUGR. So EFW are less than 10 centers were included in the study. So overall, they had 146 fetuses with both karyotype and CMA performed. And out of that, 11 had pathogenic and likely pathogenic CMPs. And this places the overall detection rate at about 7%. Okay, so in this situation, okay, this resulted in an incremental yield of 3.6% in CMA compared with karyotype, and this kind of ties in with the previous systemic review that was presented earlier. Okay, but to note that out of these fetuses, 2.1% of moose was reported, but moose was actually not included as a genetic abnormality in this study. So if we look at what are the pathogenic CMA results that were derived, you can see that there was one case of uniparental disomy, Prader-Willi syndrome, and also we have microdeletions at 19q, 12A13.2, 12q as well as 19p. So in terms of the karyotypic abnormalities that the paper wrote about, we have one case of Wohl-Hirschhorn, 47XXY, 45-0X, and trisomy 18. However, 47XXY, which is Klinefelter syndrome, is usually considered as an incidental finding, as this is not usually associated with FGR. In this paper, they highlighted that this case of trisomy 18 on the karyotype actually had a normal CMA, which emphasizes that certain CMA platforms are unable to pick up low-level mosaicism, and for this particular patient, there was mostly T18 and 30% on the interphasic cells. So this discussion, in summary, says that CMA provides a substantial additional genetic information compared with karyotype and should be performed in case of isolated FGR. However, for cases in late onset IUGR or IUGR that is diagnosed beyond 32 weeks, more studies are needed to investigate the utility of offering CMA for these cases. So this morning, we learned from Li Ying's talk about our limitations of CMA. We know that for certain platforms like the CGH arrays, we are unable to pick up low-level mosaicisms of less than 10 to 15%. Some triploidies would be lost if CGH arrays are also used. Uniparental disomy can also be missed as well. Retardation changes and neurogenic diseases will need further testing to address this question. So what will be next? I think this is of no surprise that we'll be talking about WES, and Prof. Laura has already gone through some of the landmark papers, so I know I'm on the right track. Okay, but let's go through again. So in this meta-analysis, okay, they included prospective and retrospective cohort studies and case series, and only papers that had more than 5 cases of short long wounds with or without IUGR, and with a non-diagnostic CMA and karyotype. And they looked at the incremental yield calculated for each study. So the results showed that apparent incremental yields with prenatal sequencing were 4% in isolated IUGR, with evidence of placental insufficiency, 30% in IUGR with additional structural anomalies, 48% in isolated short long wounds, and 68% in short long wounds with additional skeletal anomalies. So this ties in with Wei Qing's talk that the incremental yield for WES is actually very, very much higher if there are any skeletal findings. The conclusion from the study shows that prenatal exome sequencing has a substantial incremental yield over CMA in cases of isolated and non-isolated fetal short long wounds or IUGR with multisystemic abnormalities, which we already know. However, in this paper, the data do not support the use of prenatal sequencing in cases with isolated IUGR with evidence of placental insufficiency. So as Prof. Aski has earlier mentioned, sometimes the short long wounds may be an evolving finding of IUGR, and which may manifest a little bit earlier than the actual decrease of the AC itself. So further studies are required to assess the value of prenatal sequencing in this situation. So there was also another systemic review and meta-analysis, which was previously brought up, and this is by the Anthony Morel group. And the aim is to determine the diagnostic yield of exome sequencing above that of CMA or karyotyping in fetuses with isolated FGR. So this research question is much cleaner than the previous paper in the sense that this was truly isolated FGR. So this review included systemic review of studies with only fetuses with FGR in absence of FAs and negative CMA or karyotyping results. So we included 8 studies, and it goes to 146. And only the pathogenic or the likely pathogenic variants are considered positive of a fetal phenotype. And 17 cases out of this 146 were found to have a pathogenic variant. So these are the papers that were included from the study. And it was good that they included what was the exact definition of FGR. However, you can still see that in the few papers, the definition of FGR was still not well defined. So the study concludes that apparently isolated FGR in the absence of structural abnormalities, normal chromosomes at CMA or karyotyping actually demonstrates a 12% incremental diagnostic yield. And what are the ES abnormalities that were picked up in this series? So you can see that we have corneal lineage syndrome. We also picked up the George syndrome in this paper, achondroplasia, which was a concern from the audience this morning, as well as collagen diseases like Ehlers-Danlos syndrome. So this is a summary of the major societies guidelines in terms of genetic testing and IUGR. As you can see, there is no agreement in terms of what we do. So the last paper for exome sequencing is actually quite new, and that has not been included in most of the society guidelines. The latest guideline for IUGR was actually published by ISUOG early this year. And you can see that they are very pragmatic. They say that, okay, if you have severely SGA fetus with structural anomalies, okay, you should do invasive diagnostic testing. However, in a non-anomalous fetus, before 23 weeks, especially if the uterine artery doctor is normal, you can consider it, okay? And analysis should at minimum include a microarray to detect microdeletions and microinsertions. And in this guideline, they referred to the first systemic review that I shared about exome sequencing, and they said that exome sequencing should only be considered in cases with multisystemic abnormalities or isolated short long bones. However, for FIGO, okay, this is their definition, okay, and we should consider MSNTCs for karyotype, okay, and as well as microarray PCR for infectious agents, okay, to women is suspected FGR, especially in cases with early onset severe IUGR, okay, and of course tying in the scan findings, okay, and the absence of a placental cause. Okay, however, the FIGO ended the segment of the guideline by saying that this temptation to substitute an annual by NIPT in this context should be strongly resisted. So now we move on to the placental cause of IUGR, and we have another case study to illustrate. So this is a 34-year-old lady. She's a para 2 MPD. She has 2 previous normal deliveries, 2 previous children with normal birth weights. Otherwise, medically, she has alpha tau carrier. There's not much of a concern. She has a normal BMI. So I thank my counselor for giving me this case, and you can see that the FTS report is high risk for all 3 trisomies. At the same time, you notice that the PEP-A level is extremely low. Okay? And when we offered the NIPT, it came back as no result because of low fetal fraction. So what does it ring a bell about? Okay, I see my counselor now on the table. Okay, so the patient chose to have a CBS, okay, and the CBS came back as this, this spectacular looking result again. So, of all 28 metaphases, 23 showed an abnormal fetal karyotype with trisomy 16, okay, and the other 5 showed a deleted chromosome 10q in addition to trisomy 16. However, if you look at this result, you would expect that this baby would not be happily surviving and having a normal scan finding. Yeah, so in actual fact, this pregnancy was actually ongoing. So this points us in the direction of a fetal placental karyotypic discordance. Okay, and this was the CBS result. And subsequently, the patient had an MSNTCs, which showed 46XX fetus. So in this situation, okay, because of the fact that this chromosome involved was chromosome 16, so we had to exclude any uniparental disomy of the chromosome 16, and thankfully this will return as no evidence. Okay. So for some of us here, if we say that, oh, okay, the MSNT is normal, all right, let's just return this patient to routine obstetric visits. Okay. However, the next concern that we should have is in the context of a confined placental mosaicism. We are also worried about the sick placenta, which may manifest as preeclampsia as well as IUGR. So although the screening scan didn't really show very much structural abnormalities, just some mild TR as well as a persistent SPC, which was considered normal variant at this point. Okay, and the baby had a normal growth scan, in fact, at week 28. However, when the baby came with spontaneous labor at 37 weeks, the birth weight was only 2.160 grams. Luckily, the mother did not manifest any clinical features of preeclampsia. So in this situation, when you look at the FTS report, you can have some alarm bells ringing to tell us that this perhaps could be a case of confined placental mosaicism. However, if we did not do the CBS, we would not have been able to find out for sure that the placenta was abnormal in terms of the genetics. However, in this situation, we should resist the temptation of putting this patient back to routine obstetric recall, and we should still follow up this patient with serial growth scans. So confined placenta mosaicism is complicated as well. So this morning we talked about it a little bit. Okay, and we know that this is because there are some changes in terms of the genetic makeup in the placenta, and we divide it into type 1, 2, and 3. And if you read the literature, majority of the cases with adverse outcomes come from the CPM type 3. Okay, so trisomy 16 is one of the most common CPM cases that we come across. Okay, and there is a paper, a cohort study recently to talk about what are the actual risk profile for patients with CPM in terms of fetal labor, preeclampsia. Okay, and in this series, they found 215 cases of CPM. Okay, and they found that fetal growth restriction and low birth weight below the 10 centile were actually seen in 34% and 23.1%. And when they exclude cases that are trisomy 16 because of its well-known associations with adverse outcomes, you can see that 29.1% of remaining cases still showed FGR, and 17.9% had an eventual growth rate of less than 10%. So the authors concluded that even in this situation, any form of CPM, whether it is type 3 CPM, whether it is not trisomy 16, we should still be following these pregnancies up carefully. And amongst the cases of CPM, the other most common CPM case was associated with trisomy 7. Okay, so this was what the authors concluded. So when should we suspect a CPM? If you see an ultrasound, a baby looking very happy on the ultrasound, and abnormal CVS result that would usually be associated with miscarriage or stillbirth, or an NIPT result that shows very abnormal chromosomal aberrations, and an endocentesis showing normal keratitis DNA, then we would need to have the alarm bell screening for CPM. Okay, so this is kind of my own clinical application to end the lecture. So when FGR is diagnosed, what kind of approach should we take? So in the era of Down syndrome screening, we know that if we had done the FTS and NIPT, we would have addressed the high-risk results accordingly and exclude the aneuploidy and chromosomal abnormal fetuses from the start. So we need a very good sonography assessment with Doppler assessment. And a lot of studies have said that, apparently isolated FGR is not really apparent until you have the postnatal phenotype to compare and to see whether there are any more further evolving changes on the scan. We have to offer the choice of genetic testing, so the major societies have already stated what they think is correct. However, this is still a discussion with the patient, and in Singapore, we are pretty much limited by the upper limit of termination, which is 24 weeks. And any intention of testing beyond 24 weeks, we will need to explore the patient. What is the question that you're answering, and what is it that you want us to tell you? Because sometimes the patients will say, oh, I want reassurance, and sometimes they may not be quite ready for an abnormal result. And sometimes, if you were to send a WES, in the absence of other scan features, for example, the yield of the WES could be compromised. And sometimes it may be a little bit more practical to send the WES after the baby is delivered and after we have examined the baby. We need to also monitor for evolving sonographic ultrasound signs and correlate with postnatal findings as well. So if we suspect CPM, we need serial monitoring for fetal growth if FGR has not already been set in, and we need to survey for premature birth because there's actually a 20% risk associations with that, as well as surveillance for preeclampsia and IUMP. So in summary, chromosomal abnormalities account for 90% of isolated FGR. However, this yield for karyotype has found to be decreased due to the increased uptake of Down syndrome screening in the first trimester in recent years. CMA has an incremental yield of 3.6 to 4% over karyotyping for isolated FGR in recent meta-analysis. And there's a 12% yield, up to a 12% yield for exome sequencing and isolated FGR and normal CMA of karyotyping. And CPM is associated with adverse birth outcomes and hence should still be managed as high risk even though the endocentesis is normal. And there are limitations in interpreting the current studies, okay, including varying definitions of IUGR, exclusion or inclusion of VUS as part of genetic abnormality, and the definition of what is isolated FGR. And clinical application should consider patients' acceptance, cost, intention of testing, and the upper limit of termination of the lower setting. And with that, I thank you for your attention.
Thank you very much for